Hello again, my student. We are in our last lecture with the grading of benign prostatic hyperplasia by digital rectal exam. Now we are going to continue with where the American Urological Association has issued a guideline on the management of the benign prostatic hyperplasia. The investigations can be grouped into three categories: laboratory test, imaging, and functional assessment or function assessment. This picture shows that the management getting from the initial evaluation, history, digital rectal exam, urine analysis, and prostate specific antigen, and going so on into a surgery or watchful waiting as we are going to take. The urine analysis and urine culture, the urine examination using a dipstick method or via centrifuged sediment evaluation to assess the presence of blood, leukocytes, bacteria, protein, or glucose in urine. If the initial urine analysis findings indicate an abnormality, a urine culture may be useful to exclude infections or infectious causes of irritative voiding. The electrolytes are also examined: blood urea nitrogen and creatinine. These evaluations are useful screening tools for chronic renal insufficiency in patients who have high post-void residual or post-voiding residual in urine volumes. Also, we have the prostate-specific antigen, which one of the most significant tests given to the patient with benign prostatic hyperplasia. The benign prostatic hyperplasia does not cause prostate cancer. Men at risk for benign prostatic hyperplasia are also at risk for prostate cancer and should be screened accordingly. The current American Cancer Society guideline for early detection for prostate cancer stresses the importance of involvement. The involving men in the decision whether to test for prostate cancer. If the patient wishes to proceed with screening, the American Cancer Society recommended that the screening to start at the following age: the age 50 years in men at average risk for prostate cancer who are expected to live at least 10 years or 10 more years of his age. The age 45 years in men at high risk for prostate cancer where they are the African American and men with a first degree relative diagnosed with the prostate cancer before age 65. The age 40 years in men at very high risk. Those with more than one first degree relative who had prostate cancer at an early age. Imaging studies. The imaging studies, the first one of those imaging studies are ultrasonography. Ultrasonography should be taken to the abdominal, renal, transrectal, are useful for helping determine bladder and the prostate size and the degree of hydronephrosis. In patients with urinary retention or signs of renal insufficiency, transrectal ultrasonography of the prostate is recommended in selected patients to determine the dimension and volume of the prostate gland. In patients with elevated prostate-specific antigen levels, the TRUS guided biopsy may be indicated to assess for prostate cancer. Those pictures show us how to detect the volume of prostate by the transrectal ultrasound. And the second picture is a transrectal ultrasound probe with biopsy needle. The imaging of the upper tract is indicated in patients who present with any of the following: the concomitant hematuria, a history of urolithiasis, an elevated creatinine level, high post-voiding volume, history of upper urinary tract infection, and other imaging studies such as computed tomography scanning and the magnetic resonance imaging or MRI have no role in the evaluation and treatment of uncomplicated benign prostatic hyperplasia. The cystoscopy. Cystoscopy is not routinely recommended to determine the need for treatment. While we have a suspect, the patient have a progress from the benign to the malignant tumors, we are going to detect by cystoscopy. It may assist in choosing the surgical approach in patients opting for invasive therapy when marked obstructive symptoms exist in the setting of relative minimal prostate enlargement. Cystoscopy may be useful to identify a high bladder neck, urethral structure of other pathology. The picture A shows a normal appearance of the outlet of the bladder, while the picture B, a moderate benign prostatic hyperplasia with urethral obstruction. The functional assessment. The functional assessment shows how to measurement of flow rate, determination of post-voiding residual urine, and the pressure flow studies are considered optional. The cystometrograms and urodynamic profiles are received for patients with suspected neurologic disease or those who have failed prostate surgery. Now we are going to talk how to manage a patient with benign prostatic hyperplasia. The options of management include a watchful waiting, as we mentioned when we have an options in the first assessment, which are guided by a questionnaire developed by AUA, and medical therapy, and minimally invasive therapy, and surgery. The watchful waiting or self-help. Self-help are always done by the patient itself. The watchful waiting is appropriate management of men with mild symptoms, score 0 to 7, by the scores of the IBSS. Men with moderate or severe symptoms can also be managed in this fashion if they choose. A significant proportion of men with lower urinary tract symptoms will not choose a medical or surgical intervention because the symptoms are not bothersome. The complications of treatment are perceived to be greater than the inconvenience of the symptoms, and there is reluctance or to take a daily pill. Those daily pill owing to side effects and or the cost of treatment. Self-management could be considered as first-line treatment for men with lower urinary tract symptoms. The main components of self-management program is education and reassurance, fluid management, caffeine and alcohol avoidance, and concurrent medication. Education and reassurance and the fluid management is advised a daily fluid intake of 1500 or 1500 to 2000 ml. Also, those are the lines of treatment where we have to stop our caffeine and alcohol consumption, and the concurrent medication should be taken, and types of toileting and bladder retraining to emptying the bladder, or we have advised the man to double void. The double void is getting void when he have desire, and start another voiding after he is getting end his first voiding without getting out of the toilet, of course. Advise urethral milking for men with post-micturition trouble. Also, we have avoid constipation in men with lower urinary tract symptoms. The medical therapy. The medical therapy has two lines. Of course, we have to give the medical therapies extensively investigated for the lower urinary tract symptoms, and benign prostatic hyperplasia will be included, as we mentioned, two lines, alpha androgenic blockers and 5-alpha reductase inhibitors. And also in minimal usage, we have to use the numerous plant extracts. The alpha blockers are used, the rationale for androgenic blockers in the treatment of lower urinary tract symptoms is based on the hypothesis that the pathophysiology of loads in part caused by BOO, which is mediated by alpha-1 receptors or adrenoceptors associated with the prostatic smooth muscles. The human prostate and the bladder base contains alpha-1 receptors, and the prostate shown a contractile response to corresponding agonist. This table shows us the classification of alpha androgenic blockers and recommended doses. Those are the medications are used The second line of treatment is 5-alpha reductase inhibitors, which is called the finasteride, is a competitive inhibitor of the enzyme 5-alpha reductase. This medication is lowers serum and intraprostatic the DHT levels, or the two isozymes type 1 and type 2 of 5-alpha reductase exist. The prostate volume regression was maximal at 6 months. The greatest change in symptoms score and BFR occurred within the first 2 months of initiative of active treatment. The prostate cancer prevention trial showed that this medication reduced the incidence of diagnosed prostate cancer. There was an increased incidence of high-grade disease, possibly because of the volume change effect, which was also seen with dutasteride or the something of another medication or one of the 5-alpha anhydrase inhibitors, as shown in the slide above us. The combination therapy. The combination therapy is a combination of alpha blockers and 5-alpha reductase inhibitors. The phytotherapy is a herbal therapy. The phytotherapy use of plant and herbs for the treatment of lower urinary tract symptoms and benign prostatic hyperplasia. These agents are popular in Europe, particularly in France, Austria, and Germany. The composition of plant extract is very complex. They contain a wide variety of chemical compounds, which include phytosterols, plant oil, fatty acids, and phytoestrogens. This table shows the origin of plant extracts and component of plant extracts. The suggested mechanism of action of phytotherapeutic agents is inhibition of 5-alpha reductase, anti-inflammatory action, interferences with growth factors, anti-androgenic effect, estrogenic effect, inhibition of aromatase, decrease of sex hormone binding globulin. Those actions are getting to reduce the LUTS and benign prostatic hyperplasia symptoms. Now we are going to take the end of the lines of all lines of therapy. When we have no response to the other lines of therapy, we are going to get the surgical therapy. The surgical therapy in benign prostatic hyperplasia patients, we have many types of surgeries. The first one is transurethral resection of the prostate. The current indication for transurethral resection of the prostate is the moderate 8 to 19 to severe, which is 20 to 35 lower urinary tract infection. So we have the choices in the moderate and severe urinary tract symptoms or lower urinary tract symptoms or benign prostatic hyperplasia. We have going to choose the surgical therapy. This picture is show us how does the transurethral resection occur. Some surgeries use as a modification of the Nesbit or encirclement approach. The complications of transurethral prostatectomy is, and we have an early complications which are the hemorrhage, resection errors, transurethral resection syndrome, and obturator nerve stimulation, intraoperative priapism, and sepsis. The late complications. The first complication is bladder neck contracture and urethral structure and incontinence and impotency. The transurethral syndrome. This is a complex syndrome of a fluid overload, delusional hypernatremia, and hemolysis due to systemic absorption of large amount of irrigant, especially in patients with a gland size larger than 45 gram and resection time of more than 90 minutes. The second choice of incision of surgeries is transurethral incision of the prostate, as shown in the picture. Not resection, but incision. The incision is started at the urethral orifice and carried through the bladder, neck, up to the verumentum. This procedure is done bilaterally. The transurethral vaporization of the prostate, TUVP. This ablative technique uses photo or electroevaporation to ablate obstruction prostate tissue. The holmium laser or HOLEB, also done to treat the benign prostatic hyperplasia. The simple or subtotal prostatectomy, which is done in the indication of where the glands more than 100 gram in the most severe cases. The transurethral microwave thermotherapy. The microwave hyperthermia is most commonly delivered with a transurethral catheter. Some devices cool the urethral mucosa to decrease the risk of injury. If temperature are not more than 45 centigrade, cooling is unnecessary. Thank you for listening. Then we are talking about the nursing diagnosis and nursing management in our next lecture. Thank you very much.